So thank you to Roger for asking me to speak, and thank you for everybody to attend such an important topic, and hopefully you'll come away with not just some practical aspects to implement in your day-to-day practice, but also from the questions that are coming from the audience. I understand that people are looking to understand exactly why people would put themselves through this suffering of fasting all day, and I think from Sylvia's question that she asked earlier, just to say the fasting day is in fact, for a spiritually conscious person, much more important than the feast. So culturally, the feast is what you see, but for a person who is the one that insists on fasting the day and doesn't want to listen to the doctor's advice, the fast is much more important than the feast to them. So yes, to Chris Parks, the modifiability of the diet is there, particularly if you respect and acknowledge their will and need to fast, and you work with them for that, then I think you may be able to negotiate. So the outline for today's talk, there's some overlap with Marwan's talk, so I'm going to skip right through some of the slides, understanding, the practical aspects about Ramadan, but the spiritual significance I think will be important for you to understand, so you know where your patients are coming from. I would like to very briefly review some of the literature that I came across, which is very sparse in regards to the consequences of fasting during pregnancy, both with and without diabetes. And I would like to just give you an idea about what we did at Bankstown Lidcombe Hospital in terms of developing guidelines to assist with knowing what to do if they choose to fast, and also some guidelines just for our local health professionals in terms of what advice to give specifically for our patients who are deciding to fast during their pregnancy with a diagnosis of GDM or type 1 or 2 diabetes. So as Marwan said, fasting is an essential component to many religions. The only thing that I'll add there is that in Islam, what Marwan alluded to was that you all know about Ramadan fasting, but the other thing that we don't notice, and people will never volunteer to you, is that some very devout people, particularly older women in the community, will fast on Mondays and Thursdays. And the reason it's Monday and Thursday specifically is that was a tradition of the Prophet, peace be upon him. He used to fast Monday and Thursday. It's a completely voluntary fast, but as you must understand, voluntary does not mean it's negotiable necessarily. So it's voluntary that that's what they want to do, but it's not compulsory, which means they don't have to make up days that they miss. The other thing that some people do is they fast the 3 middle days of the month. So that's why that can be very random days of the Gregorian calendar, because it's the 13th, 14th and 15th day of the lunar calendar, which is often quite out of sync with the Gregorian calendar. So why do Muslims fast? As Marwan said, it's a pillar of Islam, and what you need to understand is that Islam has 5 pillars, and a pillar means it's a basic foundation of your religion. So belief in God is the first foundation. The second one is to pray 5 times a day, which practicing Muslims who fast will always try and do. The third one is to pay a charity every year. The fourth pillar for them is fasting. So fasting in the month of Ramadan isn't just some whimsical thing that they can or can't do. It's something that they value very strongly. And the fifth one, if they're able to via health and finance, is to go to Mecca. So it forms a basis of their religion. Now, why is it a significant time? I guess for you to understand why it's significant, that will help you to understand where they're coming from. And I think when the health practitioner understands that, it puts them in a much stronger position to gain the trust of the patient and enable them to be honest in their communication with you so that you can then benefit them. So what is the spiritual significance of it? So it's believed that the first verses of the Holy Quran, which is the holy scripture to Muslims, was revealed during the month of Ramadan. And for this reason, it's also actually known as the month of Quran. And the other thing is the prayers in the evening. The reason that they happen is that there's full recitation of the Quran, and it's hoped that over the course of the entire month, the whole Quran will be recited during those prayers. In addition, they'll spend times during the day reciting the Quran. And many Muslims at that time will try and increase their acts of charity, improve their character. And the reason I bring this up is because I think that this is an opportunity for us as health professionals to target this aspect of Ramadan and saying, okay, well, if you're going to be really insistent on fasting Ramadan, let's see what we can fix in your day-to-day habits that's going to improve your overall health and your diabetes. So smoking cessation, think about that. If they can fast for an entire day without smoking, then this is a great opportunity to talk about smoking cessation and encourage that, as well as improving their lifestyle habits, the way they eat, the dietary recommendations, some minimal amount of exercise also. As you know, it lasts for a month. We went through that with Marwan. Now, this is just a very quick slide to show how different the fasting times can be across the world. So if you look down to the second last column in green, Sydney, Australia sits really fantastically well in these few years because Ramadan fits into winter for us, so it's a really good time. And also, I guess this is a really good point because a lot of your patients will insist on fasting at this time because it actually is really easy to fast only 11 hours compared to how it could be in the summer months. And you will find in the summer months that people themselves will say they don't want to fast. Okay, so it will not be as much of a problem, I don't think, in summer, except for really diehard people. But in winter, some of them will really be willing to want to try that fast because they want to take the opportunity, even though they know they don't have to. So the definitions Marwan went through already. So suhoor, which is the pre-dawn meal, always ask about that. And some people will prefer to miss that because they want to sleep, but you should encourage them to observe that. And I think as a health professional, particularly if you're not a Muslim and you ask them about the pre-dawn meal, they'll think, oh, okay, well, you know what you're talking about, so maybe I should listen to you, you know, if you're willing to engage with me. The iftar, everybody knows about that. And the tarawih prayer, which I just want to literally translate what it means. Tarawih means rests. So the reason they're called rest prayers is because they happen in small cycles, so you rest in between them, but they can go over an hour in prayer. And if anybody knows how Muslims pray, it's quite a physical activity, so it's not sitting down and doing nothing. There's a lot of movement in a Muslim prayer, and so it does form part of an exercise routine which you can encourage for your patients as well. Particularly some patients who decide to sit down for the entire prayer, when in fact you shouldn't be sitting down. This is the time to say, well, you can stand up. Why don't you just stand up in your prayer? That's a good form of exercise instead of remaining sedentary. So I sort of try and encourage people to do that. In terms of the exemption, so it's very, very clear. Young children, old people, sick people, travelling people, anybody who doesn't have a mental capability or responsibility. The other important thing, though, is in going towards pregnancy, it's not just pregnancy in which women are exempted from fasting. It's pregnant women, it's suckling women, and it's menstruating women. And in addition to that, it's the women in the postpartum period where they have the postpartum bleeding. So for a Muslim woman during a pregnancy, if she does not feel that she is unwell, she is definitely not going to want to give up fasting because she knows afterwards during the breastfeeding time, she's definitely not going to fast because that's even harder for her. There's so many other times where she can't fast. So when she feels well, she doesn't want to give up that opportunity unless we educate her appropriately. And there's a very clear verse in the Quran in the second chapter that says all of these people do not need to fast. God does not want any difficulty upon you. And in fact, the way that I put it for people is that if you are very sick and I'm giving you a very clear instruction not to fast, you're actually harming yourself and you're going against the grain of what Ramadan means because God doesn't want you to be harming yourself. So that's important too. Now, I just wanted to bring up there, we talk about the risks of fasting all the time, and I think that it is important in this day and age that we do look at the other side of that, and that there is a lot of benefits for fasting. There are a lot of proponents out there talking about intermittent fasting, weight management with the 5-2 diet, which funnily enough reflects a lot of the Muslim practice of fasting 2 days a week every Monday and Thursday. It's pretty much similar to a 5-2 diet. There are a lot of benefits that some people might come back to you and say, well, you don't want me to fast Ramadan, but then I'm watching on the news and it's saying, well, if I fast, that it reduces my risk of diabetes, it gives me weight loss. So what's your problem with that? Okay, so we need to understand that you can look at things both ways. The risks we've already spoken about, and as we know, people who are exempt from fasting will still insist on doing it, and why is this the case? Women perceive themselves as fit to fast, and pregnant women without diabetes often do fast without any complications, and they definitely do not perceive themselves as to be in the category of an ill patient who needs to be exempt, even though they know they have the exemption. So from my experience, when I see Muslim women, some will say, well, I'll just see how I go. I'll have a try. Or they might do an intermittent fast. They fast every second day. They're not trying to be harmful. They're just trying to enjoy the atmosphere, but not harm themselves or their babies. So in terms of review of the literature, so this is a little bit haphazard, but first of all, I'm just going to look at a study or two that look at the glycemic control in pregnant women who had diabetes and fasted during Ramadan. And then there's some fetal outcome data on pregnant women who fasted Ramadan but do not have diabetes. And then looking at the attitudes of pregnant women, both with and without diabetes, to the practice of fasting during their pregnancies. So in this study, this was a study in Iran that looked at a retrospective cohort of pregnant women with diabetes. That was published in the Iranian Medical Journal, but it's a university hospital in Malaysia. Between 2007 and 2009, all the women who had diabetes during their pregnancy and were on insulin and decided to carry out the Ramadan fast were included in the study. And so from this group, there was 37 women, data collected on 37 women who opted to fast during this period, 24 of which had type 2 diabetes, the remainder had GDM. Now, the median number of days fasted in both of the type 2 diabetic group and the GDM group was about 25 days, which is quite a lot. It's almost the whole month. The way they monitored blood glucose in this study is not really typical of how we would do it in Australia or how the international guidelines would be. So they just did pre-meal, so pre-early breakfast and pre-dinner blood glucose, and then a pre-bed blood glucose reading. So the problem with that obviously is that they're not going to pick up any post-iftar hyperglycemia that you would expect to see. But what they found in this study anyway is that they were on insulin. There was no recorded hypoglycemic events. They found a reduced fructosamine level during and after Ramadan, which indicates an improvement in recent glycemic control. And there was no reported increase in fetal distress via various fetal parameters or fetal death, but there wasn't enough measured from the fetal level to look at more specific things. This is another study that was looking again at women in Malaysia, and just to bear in mind, Malaysia is sitting at the equator, so the fast in Malaysia is probably on average about 14 hours, and it's the same all year round, so that's pretty easy. So they can have a management plan that applies all year round, unlike us in Australia where we have to change things up a bit, and the same with the Northern Hemisphere. So this was a prospective cohort study, and it was just looking to see how safe once or twice daily NPH insulin was. And basically they looked at HbA1c and HbA1c, fasting blood glucose, serum fructosamine, all of which reduced a little bit through Ramadan. Also, with the insulin requirements, they found that overall, okay, so on average, before Ramadan, the women were on about 40 units of insulin a day. After Ramadan, their total daily requirement was down to about 38.5 on average. But during, of course, it was about half that. But what they found is that in those women who fasted, they needed, well, even when they were back to their usual diet, a little bit less insulin than they needed before they started. And most of the women were able to fast at least half of the month without any complications. So what about the effect of fasting Ramadan on fetal development and maternal health? Now, there are really not very many studies about this. I'm sure Dr. Hassanein has a huge amount of knowledge about this area since he's looking at this specifically, which is really exciting for me to hear about a little bit later. But in a non-diabetic population, there's been a few scattered studies looking at this. So in one study, there was 36 women with uncomplicated pregnancies, greater than 20 weeks gestation, and those who fasted Ramadan were included in the study group, compared to a control group of about 30 women. And they looked at a whole lot of fetal parameters. And basically, they also looked at the effect of fasting on the mother using beta-hydroxybutyrate as a indication of starvation, as well as glucose, urinary concentration of ketones. On average, they fasted for about 18 days, and the mean maternal glucose level was significantly lower in the study group, so those who fasted Ramadan compared to the control group, and there was no excess ketones or adverse effects from those parameters that they looked at. However, there have been other studies that do show some adverse effects. So looking at a group in the Netherlands, they looked at one study which reported a lower mean birth weight in women who fasted during the first trimester. But this was not shown for women who fasted any time in the second or third trimester. So it's just women who fasted in the third trimester, and they had babies who on average were about 270 grams lighter than the group who did not fast, than the general cohort. Several studies in Iran that did not show any difference in birth weight. Other fetal parameters, so there has been study looking at uterine artery Doppler flow indices. Some have shown increase, some have shown decrease. The same with maternal oxidative stress, fluid index, amniotic fluid index and volume. There was a study in Turkey that looked at women who fasted Ramadan, but it was in a summer hot month. Okay, so it was a very long day, and in these women there was an increased incidence of oligohydramnios. So there was reduced amniotic fluid in the fasting group who fasted for more than 20 days in a long, hot summer month. Another study in Turkey, just published in 2016, showed some maternal renal dysfunction, as indicated by blood urea nitrogen and a few other things, that showed that there was some evidence of maternal renal compromise and some increased fetal renal artery Doppler indices. In Lebanon, there was a group of 400 women that were looked at, again, fasting in pregnancy without diabetes, and there was no increased rate of preterm delivery, but other studies have shown that there may be increased rate of preterm labour, so that's not conclusive. So what are the attitudes and practices of women? What do we know from around the world? So there was a study in the UK, who Dr. Hasnain is on the authorship of, fasting among pregnant women with diabetes during Ramadan. So this was a standardised questionnaire across 4 specialist centres in London, and in summary there was 48 women surveyed, average age around 32 years, majority of which had GDM. Of these, 30% were on insulin, and 10% of the cohort said they fasted during pregnancy. 23% women who did not fast had a history of hypoglycemia, so they concluded from this that having a history of hypo meant the woman would be less likely to choose to fast. Conversely, having no history of hypoglycemia or complications would make them more likely to choose to fast. Immigrants and rural-based women were also more likely to choose to fast. In terms of the question about whether it's their husbands that make them fast or encourage them or discourage them, in fact, just as with our study, the husbands tend to discourage fasting, not encourage it, when they felt the women were endangering themselves or the baby. And women were just as likely to consult a religious scholar as they were to consult their health professional. So that's pretty important. The health professional rate's just as important as a religious scholar. So you need to know where your standing is with these women, which is important. In the US, in Detroit, which is another high population of Muslims, they did a cross-sectional study looking at Muslim patients with an active obstetric record during the Ramadan of 2013. So they approached all women between age of 18 and 50 years who had an active obstetric record at that time of Ramadan. They approached them over the course of 1 month and asked them to complete just a written survey looking at their perceptions and attitudes relating to this topic. Again, about 37 women completed the survey. 70% did not fast in their current or most recent pregnancy during Ramadan, and 62% believed that fasting was harmful to themselves or the fetus or both. 20% reported consulting others about fasting during pregnancy, again, most influential being a Muslim scholar, followed by family relatives and healthcare providers. And what was important is the most important characteristic that was desired in a physician, as reported by these women, was somebody who was respectful of their Islamic beliefs and possessing some basic knowledge about Ramadan. So what did we do at Bankstown Hospital in the Ramadan of 2014? The background to this study is that we have a large Muslim population, so almost 30% of the Bankstown population identify as Muslim. And again, this is from the 2011 census data, which could be higher if you have a whole lot of people not identifying their religion. And I actually imagine that perhaps in the current census we might not find it to be higher, Marwan, because maybe even more people will be less likely to identify themselves as Muslim with all of the controversy prior to that census. So the aim of this study was to gain an understanding about what the attitudes and actions are of pregnant Muslim women regarding what they think their religious obligation is, what they think the risk of fasting is while pregnant, particularly if there's diabetes in the pregnancy as well, and then to use this information to develop guidelines regarding this whole process. So what we did a prospective survey of self-identified Muslim pregnant women recruited from our centre during the month of Ramadan, and the questionnaire was administered by myself at the antenatal clinic. So we had full ethics approval for this. Obviously, we approached patients that were identified as Muslim and asked them to complete this survey. We had 29 completed surveys. The majority of women had gestational diabetes. It was a gestational diabetes clinic. We only had one woman who had type 2 diabetes, and I think there was one woman who had type 1 diabetes. The mean age was almost 30, and the education level, 2/3 had completed at least a Year 12 certificate. In terms of country of birth, the majority of the Muslim community in the Bankstown area is a Middle Eastern background. This will be different to the Liverpool area, for example, where they're probably majority South Asian background. So everyone's a little bit different. And for South Asians, again, we know that their glycemic profile is a little bit different, particularly with GDM and looking at 1 hour versus 2 hour blood glucose levels. So the populations do vary a little bit. Now, what did we find? We found that 38% of women thought that abstaining from fasting was either not permissible from their religious viewpoint or we're not sure. So the converse of that is that at least 60% of women knew that that not fasting was completely okay from a religious standpoint. But there's still a good portion that weren't really sure. It wasn't definite for them. They weren't really sure if pregnancy fitted into that category. The other really important thing is that although most of them knew they could check their finger prick, as much as 30% thought that it was not permissible to do a finger prick testing. And the reason, just so you understand the reason behind that, because if you have an excessive amount of bleeding, that's breaking your fast. Okay, so they were not sure whether doing a finger prick and causing a bleed would be breaking their fast. So that's 30% of people that you can completely reassure that that's okay. More than half of the patients said that they would fast with diabetes in pregnancy, and the overwhelming majority of patients said that if they did not have diabetes in pregnancy, they would definitely fast while pregnant. So what influences their initial decision to fast or not? So this isn't breaking the fast, this is the initial decision to fast or not whilst they're pregnant. And the majority of women, of course, 72% identified their baby's health. So if there's any risk to their baby, that's the main thing that's going to make them not fast. Following that, you look at their personal health. So that's the darker blue 48% category. And the 45% category is the doctor's advice, and the 48% category is the religious advice. So their personal health, what the doctor tells them, and what they think the religious scholar says will be what makes up the rest. What their husband, friends, blah, blah, blah say is really not an issue. So we should not think that is an issue. So we should take good responsibility for that. Now, what about if they decide to fast? How can we convince them to stop fasting? If they've already made the decision that they're fasting and then they've come to see you, what can we do? And what will happen that can make them, more likely to stop fasting if we are concerned? So they really do rank the doctor's advice very importantly. So advice from the doctor that says, you know what, I know you're fasting, but I really think this is not good for you. For whatever reason, you as a health professional have decided that. That's the highest likelihood that they're going to listen, and followed by hypoglycemia. So anybody who has hypoglycemia, much more likely to stop fasting from there. Any questions at this point? All good? All right, so we developed 2 handouts from this information, one for patients and one specifically for health professionals, as I said, that we just use in-house. Our patient handout, I spent a long time revising and reviewing, and we basically have simplified it. Thank you to Robin for pointing me to the SMOG readability index to enable the handout to be readable by an average person, so it's year 8-9 level literacy. We've also translated into Arabic. In 2015, before we went to our hospital to get a formal approval for it, it was assessed, and all the patients found it very useful and very informative, very easy to read, and they were very grateful for it. So in 2016, further modifications were made. We received the gold tick for community participation, and so that's what it looks like. And I have a copy down here that I can show you as well. So basically, it's just a 2-sided A4 page. There's a lot of writing on it, but I really couldn't drop it any less than that. And basically, it gives an understanding that we know what Ramadan is to you. These are the types of diabetes. This is the possible risk to you and your baby. What to do if you're not on insulin. What to do if you are on insulin. And then in bold at the end to say that it's still recommended that you do not fast. So that's basically, I think there's, it's been received well. So what it actually says in more detail, for diet-controlled diabetes, the mainstay of therapy is really ensure that they understand they can test their blood glucose and they continue to test at the recommended times that you've recommended to them previously, to understand the risk from our point of view that postprandially, particularly at the iftar meal where there's going to be a huge amount of carbohydrates, that there is a risk of hyperglycemia, and that's where a dietitian review will be important, because if they're eating too much carbs there and they were diet controlled before, well, they may become not diet controlled during Ramadan. They may just need prandial insulin at that time, but that's an assessment that you need to make. You should still encourage exercise, just like we do with all our GDM patients. And again, you can use your knowledge of their background and talk about the Tarawih prayer, for example. Do you perform that? What is your routine in the evening? Just like Marwan said, find out that individual, what they do, and see how you can work around it if you need to. For insulin-treated patients, again, they need to monitor and they need to understand they must break their fast if they do develop hypoglycemia. So it's sort of like a contract you basically make with them, isn't it? It's sort of saying, well, we really don't want you to, but if you're going to, you need to agree to do A, B, C. And then we have some more specific recommendations for those that are on basal insulin only and those that are on prandial insulin. But these recommendations are available. I'm happy to send a soft copy to people. So what about what happened in our clinic in Ramadan 2016? So we didn't have an official survey at this stage, but our very, very capable and lovely and hard-working diabetes educators identified women that they thought might be fasting, that identified as Muslim, and they basically just put a little green dot on their card, and then they just wrote into that dot if they were fasting and how many days they fasted for that month. And from the 54 women that were identified during that month that we had through our clinic, it was documented that 18 women said they were fasting, and they could have fasted anywhere between 1 and 30 days, and an average of 12 days across that group. 33% of the cohort fasted some amount of the time, and of those women, a third were on insulin. Of those that did not fast, 50% were on insulin. So you can see, obviously, that being on insulin meant you were less likely to fast. There were no poor neonatal outcomes, but obviously this was not powered to see any of that. There were 3 twin pregnancies, incidentally, just at that time, and none of those women decided to fast, which was good. So how has this changed our practice? Basically, all women who present for GDM group education, that means English-speaking women, because those who need an interpreter don't get group education, they get one-on-one education at our service. So all those women, including non-Muslim women, and I think that's important, so it's included in a general GDM education package, just one slide saying, there are risks and recommendations about fasting during pregnancy, with specific advice about Ramadan. And then the individual women who identify as Muslim are given the patient handout that I showed you at the first visit, and they're advised not to fast by the diabetes educator. Subsequent visit with the doctor, the advice is again reinforced. If women insist on fasting, then more specific advice is given as per the guideline. And then at each visit, both with the diabetes educator and with the doctor, the decision to fast is reviewed, and we progress from there. So in conclusion, I think that overall, looking at the studies, most women choose not to fast during pregnancy if they have diabetes. And although they may not always consult the healthcare provider, the pregnant women do value the opinion of the healthcare provider. And I think that as providers, we need to be confident in our information and our advice, but we also need to be respectful in our discussion with the Muslim patients and sensitive about where they're coming from so that we can provide care on an individual basis for them. Thank you.
Okay, thank you, Sarah. We have time for 10 minutes for questions for Sarah as well as Marlon, if you'd like to ask any questions. Chris from the PA, Chris Park. Just wait. I realise your voice is usually very loud, Chris, but you do need a microphone.
Can I just ask you, if you during pregnancy, if a woman does want to fast, can you think of a phase of pregnancy you think is safer? So given that euglycemic ketoacidosis can be present late pregnancy.
Yeah, so I'm not going to comment about what I think is safe or not because I don't have the knowledge about that. But from the data, it would suggest that women in the second trimester are the ones that feel well enough to fast, so they don't have the morning sickness that they do in the first trimester, and they don't feel as tired and worn out as the third trimester. So overwhelmingly from the data that I've looked at, it's the second trimester pregnant women that are the ones that are more willing to and more capable of doing it for the longest duration through that 30 days. So we don't perform ketone testing as a rule, but some places have. But yeah, we don't. We have talked about whether we should incorporate that into the guideline, and it is mentioned in the patient handout to say that your doctor may ask you if you decide to fast to test your ketones in the at some point during the day, or if your blood glucose level is a little bit higher. But we haven't gotten specific advice about that. We've left it to the individual practitioner.
And I think the resource that you've developed is really quite valuable. Thank you. I was just saying the resource that you've put together, the patient handout, is really valuable. Are you thinking of actually introducing that or putting that out up to other health facilities across Australia?
So a lot of people have shown interest in being able to utilise this, and I think we were happy to be able to share it with whoever wanted it. Really, we just got approval from our hospital to be able to distribute it freely to patients, and other people on the community participation committee from other areas also requested it. So we are happy to disseminate that. That's not a problem. So you can just email me.
Stephen.
Yeah, hi, Stephen Collegery. Could you tell me whether there have been surveys or whether you know what the imams normally would advise?
Yeah.
Because I know what they should advise, but do they?
No, that's a good question actually, because I think overwhelmingly from my readings and from my experience and from my questioning, most of the imams, I'd say 98%, would advise not to fast. So we put a blurb at the end of our patient handout that has from the Grand Mufti of Australia in 2015, this is his statement, and I personally went and interviewed him to ask him what to say, and he said, unequivocally, if there is a potential risk to the fetus in the environment that the mother is providing during pregnancy, then there is no question about her fasting. So that's the message. But unfortunately, from the point of view of other medical practitioners, to be honest with you, there are some general practitioners out there that I hear sort of a bit blasé about whether they should fast or not. So I'm not sure if it's about their understanding about the risks of diabetes, but in terms of the imams, I think they're more on our side. I think that there might be other misinformed people that may be saying, you know what, actually there's no problem with you fasting. You should fast. Why aren't you fasting? Why are you being lazy? So I've had actually had 2 patients with type 1 diabetes who have said that their GP said that you should be able to fast. So that was a concern from my point of view. The imams, on the other hand, they are actually totally lenient. They're really on our side with this.
So are there any moves to try to perhaps discuss this more with primary care? I guess it's something very important that we have to do as a...
So I think the important thing is that they need to believe in the risk. Do you know what I mean? Because they need to believe that there is a risk. And we were talking about this before. It's not about saying that we want you to stop fasting. We need to believe that there is enough evidence about risk and then inform people that there is a risk and then leave it that way. Yeah.
My wonderful colleagues from Iraq and Bukhari University, do you have any recommendations within Iraq on pregnancy and fasting?
Thank you for your nice talk. Actually, in Iraq, the fasting is very prolonged. It's about 16, 17 hours, very hot weather, so it's quite challenging for us to manage diabetic people in that area. Yes, we agree with all what she said and demonstrate about. So I don't know about my colleagues. You have something?
Nothing about pregnancy specifically.
Thank you.
Yeah. And Victoria,
there's a few questions.
Are there any recommendations that Victoria could not? So I guess it's a lot of work we need to do.
Sorry, Natalie Wisher from the National Association of Diabetes Centres. Thank you for your presentation. I haven't got a question, just a statement that, as you said, Roger, we need to disseminate this information that we're hearing today. It's extremely valuable. So what NADC has done in partnership with Sanofi today is actually filmed today's presentations. We will be putting those on the NADC website, and we encourage everyone to share those amongst their hospitals and organisations, as well as primary care will be pushing those out to PHNs.
We also had, I guess, the privilege of having a couple of primary care practitioners involved in the new primary care society, the diabetes, so perhaps that's something else we can link up with from Wednesday night. Yes, Sylvia.
Sarah, that was a really great talk, thank you. Do you know if there's any data that looks at the duration of a fast and whether that actually selects for the poorer outcomes in some studies versus others?
So all I can extrapolate from that question, I'm not on top of all of the evidence, but just the data that come out of Turkey looking at that long hot summer day and showing some potential renal compromise and fetal compromise compared to some of the other data that's come out about shorter fasting days that didn't show anything, that may be potentially the reason for no harm versus some harm. That's all. But it's hard to compare it head to head because the environments are different, the countries are different, and then the time you'd have to wait for the same country would be years and years before you could compare it, so the variables would be high.
I was actually going to ask Shalja, who runs the GDM and diabetes service at Canterbury. Of course, no funding at all, but you know, what do you actually not a centre funding? What do you actually do with your pregnant patients?
I think when I first heard Sarah's talk a couple of years ago, so we've informally adopted their guidelines. We have a similar handout which we give to the patients, and the midwives, as educators, endocrinologists, our told is to inform that you can check your sugars, similar things as you have, but it's not on such a formal basis as you do. And in fact, we've noticed over the last few years, as we've increased our education, especially coming from midwives as well, that a lot of patients are elected not to fast, particularly women on insulin. So I think when they first have contact with the midwives or the obstetricians, their tone also dictates how they respond to what we say to them.
I was going to ask,
So that's excellent.
thank you. And Sulin at Blacktown, again, you have a reasonable size Muslim population with a lot of. You don't actually see that? Oh, okay. I can't ask you then. Okay. All right. We've got time for a couple more questions. RPA. There's no particular.
No, we don't have any particular protocol, but we do quite closely follow what's happening with the stuff in Queenstown.
Is there practice that they have to do if they're not fasting? Do they have to do any religious obligation?
That's a good question. Yes.
For not fasting? Because
Not particularly.
I'm feeling a bit conflict, spiritual conflict with not doing it.
So it's hard for you to be able to give that advice, but those women, you would ask them to perhaps speak to other, because there are a lot of other resources out there to help women have increased mindfulness and spirituality regardless of fasting or not. And the only thing that I could say is a simple statement like, I think that you will be rewarded for your efforts even if you don't fast, and in fact not fasting, you will still be, so in that terminology, you will still be rewarded for your efforts because it's out of your hands that you can't fast. So when they have that understanding, for somebody who is deeply spiritual, that's important to them, and they have plenty of other ways for them to increase their practice. Like I said, reading the Quran, that's what the mainstay of the other thing that you do during the month, so they'll be able to do that without any problem.
Question from Alif.
Just a comment. I think also to emphasise that there is a lot of variability in terms of the person's background and the country they come from. So, for example, I grew up in Turkey until I was 11, and growing up with grandparents and people who were fasting, it was always the thing that if you had diabetes, that you wouldn't need to fast. But and over the years, that I've grown to really respect people's own choice, and I think that's really important, that we have to be respectful of the person's choice and really help guide them, as you said. But just to emphasise that there is a lot of variability.
Yeah, absolutely. That's extremely important. So not one rule will apply, and that's why you just have to treat each individual with regards. And you can never assume that somebody was even intending to fast in the first place. That's the other thing. So that's the important point. Yep.
Dr. Hassan, I do look after almost like my patient of Muslim background and speak the languages. My question is, with regards to type 1 and real life arena, particularly those on the pump, my question for both speakers actually, do you tend to cut down the basal by 50% or 1/3? What's the general approach?
I'm expecting that Dr. Hassanein might give us more details about that in the actual IDF guideline this afternoon.
Okay, before we break, thank you, Sarah, for again a fantastic talk. Thank you.